The long leg splint is used to immobilize the distal femur, knee, and proximal tibia. This radiograph demonstrates a transverse distal femur fracture, whereas an oblique proximal tibia fracture is shown here. Place the patient supine on the stretcher with the leg extended. If the clinical situation allows, elevate the leg by placing the foot on an object, such as a small box, or have an assistant gently raise the leg during application. Use a piece of 6-inch Webril to measure the required length of the splint. Measure from the proximal thigh, past the knee, to a level 5 centimeters proximal to the malleoli. The splint may be extended to the metatarsal heads if immobilization of the ankle joint is required. Lay this section of Webril onto the bed, and then roll out an additional 3 layers to form the cast padding. Use 2 pieces of Webril to make the top layer, each offset from the previous layers by 50%. Next, roll out 12 to 15 layers of 6-inch plaster on top of the Webril. The plaster may be folded back and forth upon itself during this process. Several rolls of plaster may be required for the long leg splint. Soak the plaster in room temperature water until fully saturated. Raise the plaster from the bucket and remove the excess water by allowing the layers to fold down on themselves and then gently squeezing them. Lay the plaster down onto the cast padding and smooth it over with your hands. Fold the overhanging edges of the top layer of Webril over the plaster to form a single outer layer that will prevent the plaster from sticking to the elastic bandage. Apply the splint along the posterior leg. Use 6-inch elastic bandage to secure the splint to the extremity and wrap in a distal to proximal direction. Gently mold the plaster to the contours of the leg with the palms of your hands as you progress. Note that the knee should be flexed between 10 and 20 degrees. Apply a moderate amount of tension during the wrapping process. For many indications, a prefabricated knee immobilizer provides an equivalent degree of immobilization and may be used instead of a plaster long leg splint. Finally, repeat a detailed neurovascular examination of the foot. This should include assessment of sensory and motor function, as well as the dorsalis pedis pulse and capillary refill.